days of federally mandated paid vacation leave for OECD countries. And as you can see, the United States is at the far right. As an outlier, it's the only advanced economy globally that doesn't guarantee its workers any paid vacation leave. By contrast, 27 of 35 OECD countries currently mandate at least 20 days of paid vacation per year. And paid vacation may plausibly have mental health benefits, and like paid maternity leave, for which there's growing political and public support, there's this potential for policy change in the US to federally mandate paid vacation leave. So this study used data from the National Longitudinal Survey of Youth 1979, which is an ongoing longitudinal study of adults. Initially they were adolescents and young adults surveyed in 1979, and now they're past middle age. The final sample consisted of over 3,300 individuals working 30 to 90 hours per week at their primary job. And the primary outcome was depression based on the 7-item CESD scale. And then the predictor was the number of days of paid vacation leave. So I used fixed effects analysis. So we can write an equation for the association between paid vacation days and the CESD score as a continuous outcome. With this first equation, the x corresponds to the number of paid vacation days of leave. The c corresponds to the vector of time varying covariates. U corresponds to the constant individual fixed effects, and lambda corresponds to the time fixed effects. So if we take the difference between this equation at 2 time points, time 1 is when they completed the age 40 module, and time 2 when they completed the age 50 module, the individual fixed effects mu that are constant over time difference out to 0, and so we get the second equation shown here. And so the mu no longer appears in the model, so these time invariant factors, whether they're measured or not, are effectively removed as confounders. We can extend this to logistic regression by first excluding individuals with no change in depression over time, and then use the different scores in time varying covariates as the predictors of depression at age 50. So this graph shows the associations in different subgroups, and there are significant interactions with 29% lower odds of depression in women for every 10 additional days of paid vacation leave, whereas we don't see any association in men. And then if we look further in subgroups of women, we see that there are significant associations in white women and significant associations in women with 2 or more children at baseline. In the second study, I estimated the impacts of state-level social spending and income inequality on mortality. And here I used both fixed effects and instrumental variable analysis to strengthen causal inference. So why should we care about social spending? So spending on public goods such as education and healthcare, and social assistance such as cash transfers primarily benefits those of lower income. And so that would have the effect of reducing stratification by socioeconomic status and the gaps in material conditions, and should have the overall impact of improving population health and equity. And if you think about the Health Olympics, the countries with longer life expectancy do tend to have higher levels of non-medical social spending, such as countries in Scandinavia. And why should we care about income inequality? Well, we know that income inequality has been rising dramatically over the past several decades to levels last seen at the time of the Great Depression, and there are plausible reasons why income inequality may be harmful to population health. So this is a conceptual diagram for the use of an instrumental variable for the association between state social spending and mortality. And the instrumental variable is whether there's a state governor election at the end of the year of state social spending. And the association between state social spending and mortality you can imagine there can be many different confounders, and so we refer to state social spending as an endogenous variable. So by using this instrumental variable, we can isolate the random variation in state social spending that is as if it's randomly assigned, like in an RCT, and so we can get a better, less biased estimate of the causal effect. These are the estimated impacts on the probability of dying from all causes using different sets of models. But if you just focus on the red lines, where I use both fixed effects and instrumental variable analysis, you can see the point estimates and 95% confidence intervals indicating reductions of roughly 3 and 1.5 percentage points for the probability of dying, for increases in welfare and education of $250 per capita. And then for income inequality, which is measured by the Gini coefficient, an increase of 0.1 corresponds to an increase in the probability of dying of 0.6 percentage points, although it's not statistically significant. Similarly, these are the results for the probability of dying from heart disease. And here we also see reductions that are significant in the probability of dying of 1.6 and 0.8 percentage points for welfare and education, respectively. And this is on par with the reductions that we would see clinically with patients successfully treated for high blood pressure or cholesterol. So these are important changes. And then for income inequality, we see that a 0.1 increase in the Gini coefficient corresponds to a 1 percentage point increase in the probability of dying from heart disease. So again, this is an important change. And then in the third study, I estimated the impacts of federal tax policy proposals on mortality burden. And this study models tax proposals by both Donald Trump and Bernie Sanders in 2016. So this is very relevant to policies in the current administration. So I use microsimulation modeling, and microsimulation modeling enables the virtual conduct of experiments, often not ethical or feasible in the real world. So it provides an opportunity to simulate real-world health impacts of intervening on social policies such as tax policies. And I use the taxing model, which calculates liabilities under US income tax laws from individual return data, from which we can simulate what are the projected changes in after-tax income inequality based on hypothetical changes in income tax policies. And I use the IRS public use tax file, which consists of about 140,000 records or returns that are meant to be representative of the close to 143 million tax returns filed for the 2008 tax year. And the reason that I use the 2008 tax year is that after 2008, they no longer include the state of residence as an identifier in the public use file. So I looked at 5 different tax plan scenarios. The first is the base case scenario of actual income tax rates and brackets for 2008. The second and third scenarios are for 2016, the plans proposed by both Trump and Sanders. And then the fourth scenario is modifying the Sanders plan with even higher rates in the highest 3 tax brackets. So rates of 75% for those with incomes $500,000 or above. And then the fifth scenario is extending that fourth scenario to redistribute that additional revenue from increasing the tax rates in the highest tax brackets to those with incomes less than $40,000. And then to estimate the impacts on mortality, I use information or data on the annual numbers of deaths from all causes, and then estimating the population attributable risk based on previous estimates, including from the second study that I presented, on the associations between income inequality and mortality, as well as between absolute income and mortality for the redistribution scenario. So this just shows each of the tax plans with the marginal tax rates for the different tax brackets. And so you can see that the tax rates range from 10 to 35%. It's similar with the Trump plan. And then with the Sanders plan, it goes up to rates of 54% in the highest tax brackets. So these are increased to 75% in the fourth and fifth scenarios. So this just shows what are the impacts on these Gini coefficients. You can see with the Trump and Sanders plan, there's modest increases and decreases in the Gini coefficient, and then it more than doubles with the modified Sanders plan, and more than six-fold increase in, or decrease in the Gini coefficient with the fifth scenario. So translating this into the number of lives, the change in the number of deaths annually, you can see there's roughly 30,000 increase with the Trump plan, 30,000 decrease with the Sanders plan, and then close to 70,000 lives saved with the modified Sanders plan, and close to 190,000 lives saved with the last redistributive scenario. So in terms of challenges and gaps, there's still inherent limitations of causal inference despite using some of these specialized methods, and there's still lack of evidence on some of these social determinant health associations for projecting policy impacts. In terms of future directions, we still have a need to improve these methods and make data more available, such as with the case of the state identifiers no longer being provided. And we also need more incentives in epidemiology and public health to systematically bridge these gaps. So that's it. So just for in terms of the panel Q&A, I think we're short on time. So I think we'll just open it up to all of you if you have any questions for any of us on the panel. Thank you.
Thanks, really interesting talks. I wonder if you can talk about in your experience how your work or how you engage with policy members in your community, with your local governments. So we've heard a lot about the data and sort of data and policy and how they work together. Clearly, what you're focusing on, you need that political engagement or grassroots organizations or communities to kind of work towards raising the minimum wage or earned income tax credits or paid leave, all these things that are good for us. Thanks.
Great. Sure, thanks. I'll just kind of give our example too. It's been challenging, I'm going to say. It takes a lot of work and time and energy. So that's challenging as tenure track faculty. But I think our biggest success was really partnering with folks at the state level and finding the right groups, like the Women's Policy Caucus. Once we found those organizations who could help us push through, it made all the difference. So I think it's just figuring out who those organizations are and then spending the time to work carefully with them.
Yeah, so I apologize. I think we're probably going to have to transition just because we're running late. We have 2 more sessions today. So I thank the panelists very much. And I hope that people will engage you more informally to follow up with other questions that I know you provoked from really a great set of presentations. So thank you.